in one place. So as Tina said, I'm Vicki Greenberg, and it's a pleasure to be here today or this evening. And I thank you for taking time out of your schedules. Although if you were like me, I said 6 o'clock, I don't have to cook dinner, I'm there. Let the people fend for themselves at home. So I am a family nurse practitioner, and do you know what a nurse practitioner is? Okay, that's usually the first confusion that we're going to navigate here. A nurse practitioner is a registered nurse that's had advanced education and training to practice above the scope of practice of a registered nurse, kind of between a doctor and a nurse. Okay, we see patients, we diagnose illness, we prescribe medications, we order labs, we pretty much do everything, most of the things that a doctor would do in the office setting. So I have my patients, I have my own schedule, I follow my patients, and pretty much function, like I said, at the level of a physician in the office. I have been a nurse practitioner since 1997. I graduated with my degree at Cal State University of Long Beach, and prior to that I was a registered nurse working in labor and delivery. I did that for 14 years, and I just loved it, but I knew that I wanted to kind of go beyond what I was doing. So the logical step was to become a nurse practitioner, and as an OB nurse practitioner, as a labor and delivery nurse, I figured women's health is where I wanted to be. But I decided to train in family practice, and I'm glad I did, because it gave me a broad base of information. Although I have to tell you, taking care of a man for the first time was a little scary for me, because being a labor and delivery nurse, I didn't take care of men, so that was a little bit of a challenge. I started work here in Orange, and a couple people are, one of the ladies in the audience happened to be a patient of mine when I first started working over in Orange. I proceeded to take care of pregnant patients and women in the office. When the doctors that I worked for stopped delivering babies, my job was kind of eliminated as their obstetrical nurse practitioner. So I went to Irvine and practiced as a nurse practitioner there as well. During that time, I kind of put my feelers out a little bit to see what else was out there, and actually ended up getting a full-time position at the University of Phoenix, where I run the family nurse practitioner program. But my love is taking care of patients. So fast forward to here, actually when I was a labor and delivery nurse, Dr. D. Nicola was one of the doctors that used to deliver babies, and so I knew him back in, 1980, early 1980s I met him. Coincidentally, his wife was working at the University of Phoenix when I got a job there, so I knew I was destined to be a part of the D. Nicola group, and they let me come over here. It's an honor to be over here, honestly, at Caduceus, taking care of patients every Tuesday. This is our setting. It's a state-of-the-art place. The Women's Health Pod is right over here. That's where I work. And it's just a wonderful place to be. So that's enough about me, but my love is women's health. Like I said, I teach students, I teach patients, and I talk to people. I've been on the radio, I've been on TV, I've done a lot of different things in discussing women and discussing health in general. So, bioidentical hormones. First off, I'd like to say that this whole topic is one of the most misunderstood topics that there can be in women's health. And being a woman myself, and being in menopause myself, a lot of the information that I've gathered and a lot of the information I'm going to give to you is near and dear to my heart as well, because it applies to me personally as well as professionally, which I think makes it very nice when I take care of my patients. I can use personal experience along with my professional experience to tell you kind of what, what I have found. Okay, so the first thing we need to talk about when we're talking about bioidentical hormones is menopause, okay? Why do we even think about replacing hormones, putting hormones into our body? When we're young, we use hormones rather frequently. A lot of us did with birth control pills, some of the other birth control options. But menopause is when this topic of hormone replacement therapy comes into play. And menopause is the permanent cessation of menses as a result of loss of ovarian function. The clinical definition of menopause is no period of 12 months. Okay, there are blood tests that can be done to check for menopause. There are hormone levels that can be checked. They're not always reliable. But the whole issue of hormones would base it more on clinical symptoms than on lab results and numbers on a piece of paper. The average age of menopause is 51. That means people earlier and people later are all going through it. There's such a thing as surgical menopause, which is an oophorectomy. That's where the ovaries are removed. And when I was 44, that's what happened to me. I went through menopause overnight at age 44. So estrogen became something that of my best friend, at least for a while it did. Menopause can also be medically induced. It can be a result of chemotherapy, anti-estrogen therapies like tamoxifen and the like, and also radiation. So people with breast cancer, a lot of laser breast cancer and other types of cancers will go through a medically induced menopause. Sometimes it's reversible when the treatment is over, sometimes it's not. So what happens? Menopause results in a myriad of symptoms, which range from mild to severe, and I've seen them all. Vasomotor symptoms, most common that we think about: hot flashes, night sweats, moodiness, irritability, sleep disturbances, we can't sleep, we're sweating all night long. There are medical conditions that menopause can also contribute to, such as osteoporosis or bone thinning, vaginal atrophy or the thinning of the tissue, and cardiovascular disease. So not only are we concerned about menopause from a quality of life standpoint, but also from a medical standpoint in preventative health. Okay, perimenopause versus menopause. What does that mean? Well, many women come to my office and say, I think I'm in menopause. And the first thing I say to them is, are you still having periods? And if the answer is yes, then what do we know about menopause? No period for 12 months. But that doesn't mean they're not having symptoms. That doesn't mean they're not having hormones going up and down and feeling like they're in menopause. So perimenopause is usually when women start to think about hormones. We're usually in our 40s. Our periods are getting a little bit irregular. We just don't feel like we did. We maybe feel like we're gaining weight, we're getting thicker around the middle, we're more tired, we get hot, we get cranky, we get irritable. People wish we would just go away. And that's usually when I see a patient for a consultation. And the whole issue of this basically at this point is quality of life. Women usually don't do anything about this until they decide, I've had enough, I need to do something. Sometimes it's as simple as coming into the office and getting information. Sometimes they come into the office begging me to write a prescription right now and let them go to the pharmacy and fill it. Perimenopause is temporary, meaning you will eventually go through the change and your ovaries will stop working, you will stop having periods, and you will become menopausal. Women wonder what's wrong with me, and so do the people around them, their family, their loved ones. And the management varies. Age groups vary. They can be as young as late 30s, early 40s. I've had a woman who came in 56 years old, still having regular periods every month. So perimenopause can go on for quite some time. These are the 7 menopausal dwarfs. There's itchy, bitchy, sweaty, bloaty, sleepy, forgetful, and psycho. Does this sound familiar, anybody? Okay, I think before we talk about bioidentical hormones and the whole issue around it, we need to talk about some definitions and what the terms mean to get some clarity and some understanding. Bioidentical, taken from the dictionary, it is having the same molecular structure as a substance produced in the body, possessing identical molecular structure, especially in relation to an endogenously produced substance. Endogenously means internally produced substance. Bioidentical hormones, therefore, are hormones used in products that are chemically identical to those that your body produces. Those hormones include estrogen, progesterone, testosterone, thyroid, DHEA, and adrenal hormones, among others. But for our purposes, we're going to concentrate on estrogen, progesterone, and to a small degree testosterone, because we don't want to forget about testosterone either. Natural versus synthetic. This is another big area of misunderstanding. Natural simply means existing in or caused by nature, not made or caused by humankind. Synthetic, however, is a substance made by chemical synthesis especially to imitate a natural product. So already you're probably confused with this, and no wonder people come, I want something natural, I don't want synthetic, I want a bioidentical. What does it all mean, and where do I get them? That's kind of where we're going to take this talk and dispel some of those myths. Okay, what is hormone therapy? Traditional hormone therapy, or HT, used to be HRT, hormone replacement therapy. Now we're deciding we're not replacing, we're just doing therapy. I don't know why these things keep changing. But anyway, HT. It's an effective, generally well-tolerated treatment for menopausal symptoms. It replaces what is lacking, estrogen, progesterone, and to some degree testosterone. Compounded hormones, what does that mean? We hear that term as well. Bioidentical, compounded, synthetic, natural, unnatural, conjugated, you hear all of these terms. Compounded hormones are made-to-order hormones. They're mixed at a compounding pharmacy. They're useful when a clinician wants to prescribe hormones in combinations, doses, or preparations not routinely used or available to us through pharmaceutical companies and such. For example, if we want to add a little bit of testosterone, a little bit of estrogen, and maybe some progesterone, or we want to use it in a method such as a lozenge or a pellet that actually goes under the skin, things like that that we have available to us that we can't just write a prescription and go to a regular pharmacy and get. They're useful to order hormones not approved for women, such as testosterone and DHEA. I have many women who come to me and they're not as interested in estrogen and progesterone as they are in testosterone. Many women, their libido is down, they don't feel as youthful and vibrant as they used to, and men have Viagra and the women are like, well, what do we have? And the answer is not a whole heck of a lot, unfortunately. But we look at testosterone because our bodies do produce testosterone. If you have your ovaries removed, your production of testosterone is completely shut off as well, except for the small amount in the adrenal glands. So even women who go through menopause that still have their ovaries are still producing some testosterone. But it's nice to use it in certain forms to help us, and it can help us. Not always as much as we wanted it to, but it can help us. We have used male testosterone for females. The old way we prescribe it is we use androgel or one of the other testosterone products, and we tell the patient use 1/10 of the male dose. So they get this pump and they try to squeeze it out, and it's like, what's 1/10 of a male dose? Well, we don't know that either. So it's very difficult to prescribe it that way. Also, insurance companies don't want to pay for you to have testosterone because you're not a man. So it's very difficult to get approved for testosterone. And so compounding pharmacies are a way we can get lower doses for women in a more easily available form to use. Okay, hormones and WHI. Does anybody know what WHI means? Women's Health Initiative. That was a big turning point for menopause treatment in the community and medical community in general. Okay, hormone therapy has been around for about 6 decades. Women have been going through menopause for years, obviously, and back in the younger days, women didn't live very long past menopause. So maybe they lived, a few years after menopause, and then the natural lifespan, they didn't stick around to realize how much fun it could be to be without hormones for a third of your life. But nowadays, we're living to 80, 90, 100 years old. We go through menopause when we're in our 50s. Sometimes that's almost half your life that you're living with the female hormones that you had at the beginning when we were young and vibrant and pretty and thin and all that good stuff. So the researchers and scientists started to look at this and think, well, if we're lacking hormones, what's the answer? Replace what we're lacking. So they came up with a pretty much standard estrogen product, because estrogen basically is what causes most of the symptoms. And they came up with a product called Premarin. Anybody heard of Premarin? Premarin is it's not a bioidentical hormone, but it is very successful at treating menopausal symptoms. And when doctors had this available to them and started prescribing it to their patients loved it. They felt better, they felt great, they were suddenly, life seemed good again, and it was like a miracle for menopausal women. As time went by, as studies were done and we're seeing how these women are doing, they started to realize that a lot of these women were ending up with cancer of the uterus, and they couldn't quite figure out, why is this happening? This is a statistically significant increase in cancer of the uterus. And what was found was Premarin, or estrogen, which is fertilizer. If you think of estrogen as fertilizer, it builds up the lining of the uterus to get ready for a baby. That's its job. If we're building up this lining and feeding fertilizer into this uterus that's not having periods anymore, it gets thicker and thicker and thicker, and eventually can start to turn abnormal and turn cancerous. Big problem, big red flag went up. So in the mid-1990s, it became the focus of the attention is, what do we do about this? So we started to hear about progesterone being added to estrogen. Progesterone is used to support the lining of the uterus. When we have our periods, the estrogen builds up the blood, the estrogen goes down when we ovulate, the progesterone goes up, supports that blood until implantation occurs or not. If implantation does not occur, progesterone goes down and the blood comes out. So makes sense then that if we're giving these ladies estrogen, we need to give them progesterone, which is the counterbalance. And suddenly the cancer rates were going down, and we were realizing that this is a good thing, this combination hormone therapy. So Provera, which is a progesterone product that was developed, began to be used along with Premarin. Then along came a study. In 2002, because hormones are always being studied and progress is always being made and research is always being done, the National Institute of Health started a study called the Women's Health Initiative. And what that was a study to look at hormone use in women and the effects long-term on women's bodies. Remember what I said, hormone didn't live long past menopause for a long time. Now we are. Hormones, estrogen in particular, was thought to be a very protective hormone for a woman's body. Protected the skin, the bones, the heart, the brain, the bladder. And so we wanted to look at this and see, are these hormones that these women using really helping their health? Is it really promoting or producing less heart disease and less problems with stroke and breast cancer? So they rallied a bunch of women together, grabbed a big group of women, and they made two arms of the study. One was a woman with a uterus, okay, and one were women that have had a hysterectomy. Now, backtracking a little, women with a hysterectomy who took Premarin obviously didn't have any increased risk of uterine cancer. Why? Because they didn't have a uterus. So we knew that estrogen alone in those women would be safe and would be the standard of care. So the study looked at both of the women. They gave this group Premarin and Provera together, which is called Prempro. They gave this group Premarin alone, and they watched. And the study was designed to go on for about 7 or 8 years. After about 5 years or so, the study was halted. Big red flags went up. I mean, it was a mass hysteria. These women that were taking Premarin or Prempro were getting increased incidence of heart attack, stroke, breast cancer. And, any study that's starting to have deleterious effects, they're not going to continue it. The arm with the women that had the hysterectomy and were just taking the Premarin, those women were doing fine. But it was the women in the other groups. So at that point, the whole tide turned. Now hormones were poison. People stopped using them. Doctors would not prescribe them. Patients went off them. And women became miserable again. Now what do we do? So what happened at that point, the decision was made that these women are having these harmful effects and we need to stop the study and we need to change all of our ways of prescribing. However, a lot of us in the medical community looked at the study and said, this is not a good study. This is not a good sampling. The women who were having the issues, the women who were being prescribed Prempro, were brought in at different ages, anywhere from 50s to almost 80. Now, a woman who's 80 and has never been on hormones comes into a study and is given a hormone, she's going to have a problem, perhaps. Now, was she having a problem because of the hormone, or was she having a problem because she was 80 and she was going to have a heart attack anyway? It became very unclear about what the study was all about, what the results actually mean. And so the limitations of the study were that we really don't want to stop hormones, but medical legally, in our best interest for the patient, we can't promote something that could be harmful to somebody's health. So the current recommendation at that point was hormone therapy should be used only in low doses for a short time for severe vasomotor symptoms. So it was up to us to figure out what is a low dose, what is a short time, and what are severe vasomotor symptoms. So along with bioidentical hormones, okay? The thought at that point was, why are we giving women these hormones that are different than the hormones they produced before they were in menopause? Okay, we're giving them conjugated estrogen, which is actually derived from pregnant mare's urine, which is why it's called Premarin. And we're giving them Provera, which is a synthetic, or not a, shouldn't say synthetic, it's a non-bioidentical form of progesterone. When we started looking at bioidentical hormones and thinking, what if we give these women things that their body produce naturally? You know, let's look at how our bodies respond to the treatments that we give. We started to realize that some of these hormones will become very useful, and to this day are used widely. The bioidentical hormones that we talk about today are estradiol. Estradiol is the major estrogen that was produced by the ovaries. It's the strongest form of estrogen, and it's the form that goes to the cells, attaches to the receptor sites, and gives you the relief that you need for your treatment, for your symptoms, and replenishes what your body is lacking. Gives you the most bang for your buck. Estradiol, bioidentical estrogen, okay? Conjugated equine estrogen, Premarin, not a bioidentical estrogen. So when we realized that estradiol looked like it was going to be a better product to use, Premarin use went way down, and hence we've started to get into this bioidentical hormone world that we're in now. But there are other types of estrogen that are also bioidentical. There's estriol. Now, estriol is mainly elevated in pregnancy. It's produced by the placenta. It's used in the AFP screen, so the genetic testing that we do in pregnancy to test the mother's blood, which could potentially indicate a birth defect. One of the things we look at is estriol levels. It's a metabolic waste product of estradiol, so it actually is a breakdown product of the estradiol itself. It's about 8% as potent as estradiol. It's not effective as for hormone therapy by itself. And then there's estrone. Estrone is the estrogen we have when we're in menopause. Okay, we don't have no estrogen just because we're in menopause. We still have some estrogen, but the form we have is mostly estrone. It's a weaker form of estrogen. It's produced by belly fat cells, and in menopause, one of the main things I hear my patients saying is they can't lose weight around the middle. I think belly fat is one of the biggest concerns, not only for women, but men too, and general health, and it's a big problem. Estrone is produced by those cells, and it's the form found in naturally menopausal women who are not taking hormones. It's not directly active in the tissue, and is considered an estradiol precursor, so it kind of like helps to form the estradiol as we metabolize it. Then there's progesterone. Progesterone is produced by ovaries during the release of a mature egg. So when we ovulate, our progesterone levels go way up. One of the ways we can tell if a woman is ovulating when she wants to get pregnant. We measure progesterone levels about day 21 of her cycle. If they're elevated, it stands to reason she ovulated. When the progesterone goes up, it supports that blood that the estrogen fertilizer produced. And when no implantation occurs, the progesterone level goes down and the blood comes out. And then the cycle starts over and over and over. It's produced by the placenta during pregnancy to support the pregnancy. Women who are pregnant and are threatening, bleeding, and their pregnancy may be a little unstable at the beginning, often are given extra progesterone to support the pregnancy to keep them from having a miscarriage. It helps to prepare the lining of the uterus for implantation, and it is responsible for all of those good PMS symptoms we think about when we're about ready to have our period. Crankiness, bloating, oily skin, acne, cravings, irritability. and it protects the endometrium during hormone therapy like we talked about. Women who take estrogen with the uterus need progesterone to protect the lining of the uterus from cancer. So, all of this being said, what is a woman to do? How in the heck are we to know what is good for us, what we should do, what the best choices are? Well, you shouldn't really know. That's what we're here for. And the best thing for a woman to do is go to her provider and have a discussion with the provider. And when you come in and talk about your choices and what is available to you, we talk about all of these things. And these are the things that I talk about to my patients when they come to see me for a menopause consult. We talk about compounded hormones. Okay, that's usually a big question women have. Women assume that a bioidentical hormone is a compounded hormone, that it's natural and it's not synthetic. A fair estimation of what you might think about bioidentical hormones? If you remember that natural means produced by nature, is compounded hormone in a pharmacy that a pharmacist puts in a pill or a cream produced by nature? No, it's produced in a lab, so it's synthetic. It is bioidentical. It's compounded because it's produced in quantities perhaps that are not the standard doses that we have available by pharmaceutical companies. So there's many, many forms, and these compounded pharmacies are excellent pharmacies. I've used them. These pharmacists know much more than I do about all of this. They are wonderful. Patients get a good relationship with their compounding pharmacist, and some women are very, very happy. I'll just say some women are very, very happy. We'll talk about that. Part of the problem with compounding hormones, there's certain pharmacies that do it and certain ones don't. And the ones that we trust that are good are left to our judgment to decide. The FDA does not look at these pharmacies. They are not regulated. There's nobody looking to be sure that they're doing what they say they're doing. There's no safety data on compounded hormones because they're not FDA approved. Research isn't being done to look at these hormones in the degree that it is for the traditional hormones. There's no proof of less side effects. When you give a woman estrogen, you give a woman progesterone, she's going to have the same side effects, whether it's a prescription that we write you or it's a compounded preparation that the pharmacist makes for you. There's less provider experience. A lot of providers in women's health don't understand compounded hormones. And if you go to somebody who doesn't know what that is or is very biased against them, you're not going to get a good answer. You're not going to get good information. There are a lot of good compounding pharmacies out there, and some of the products are very, very useful. I will say that up front because I should have said this at the beginning, I have no conflict of interest with any drug company or anything. I have no ties with anything. I do what is best for my patients, and if this is what's best for my patient, then by all means that is what I do. But some women get relief. I'll say that again. A lot of times compounded hormones are based on saliva testing or blood testing. Okay, we're going to make this hormone for me, and they're going to measure my blood, and they're going to measure my levels, and I'm going to go to the pharmacy, and they're going to make this certain dose, and then we'll get my blood drawn again, and if it needs to be increased or decreased, one or the other, whatever, we can do that based on my blood levels. Saliva levels, they really don't reflect blood levels. So when patients want a saliva test done, I try to educate them. You're not going to get the information that we need to make a good decision, and the bottom line is you're not going to feel better. And if you do, you would have anyway. It wasn't the saliva test particularly that was the reason. When you do a blood level on a hormone, you're measuring that minute in time. Our hormone levels change from minute, to hour, to day, to day. So you come to my office, we draw your blood, your estradiol level is, to put it in perspective, a menopausal woman's runs between 20 and 80. When you're having periods, it can go up as high as 400 or so. So it kind of gives you a range of hormones. So measure your hormone and say it's 20 or less. Sometimes it's 0 for these poor menopausal women. So we take you to the compounding pharmacy and we say, okay, her level is 0, so we're going to make this product. Well, by the time the product is made and you get it home, which could be a day or two later, your hormone could be 80 or 90. They can change. So by changing doses based on blood levels, we're always chasing the results. We're always trying to catch up. And there's no data, because there's been no good studies to show that the doses I'm giving you are going to help you. They're not going to hurt you per se, but we don't know that they're going to help you. They haven't been studied to say this product delivers this much estrogen into your blood at this level for this length of time, and so there's a limitation there. And they're not usually covered by insurance. And that's a big obstacle for a lot of patients. And I tell them up front, I'll be happy to write this prescription for you. You can take it to the pharmacy. The pharmacist will work with you. We'll get this, it's a work in progress, and it'll take a while to get to where we need to be. Until we get to where you need to be, we're going to be experimenting, and you're going to be paying for every one of these experiments out of your pocket because the insurance companies won't pay for these products. Okay, the compounded hormones that we typically use in women's health, like I said before, are estrogens, progesterone, and testosterone. And we can make any combination of those. We can prescribe estrogen alone, progesterone alone, testosterone alone, 2 together, 3 together. Every one that we put together can be in different doses, so it's very complicated to do these compounding hormones. Now, fortunately, there are standard compounding doses that we know correlate pretty well with the prescriptions that we write in terms of the dosing. So we pretty much know if a woman comes in and is having these symptoms, this dose would probably be a good option for her. We're not just grasping a number out of the air. We kind of know where to start. Okay. One of the most common and most popular compounded hormones that we use for estrogen is either Biest or Triest. Now, if you look at Biest, and this is just estrogen, remember, so this will also be part of the whole recipe if we put everything together. Biest is 80 to 90% estriol. Now, remember, estriol was mostly present during pregnancy, and it's a very weak form of estrogen. It's 10 to 20% estradiol. That's why it's Biest. There's 2 different estrogens in it. A lot of women like this. There's bodies have different levels of estrogen in them normally. It's bioidentical to have different variations of estrogen. So the Biest is an available option. Triest was more widely prescribed, at least for me, than the Biest was. It contains 80% estriol, 10% estrone, which is the hormone, like we said, that is produced primarily in menopause, and 10% estradiol. So that's why it's Triest. There's 3 of them in there. Now, knowing what we know about hormones, and knowing what we know that estradiol is the most bang for your buck, it's the hormone that attaches to the receptor sites, it's what our bodies basically are craving. The compounded formulations of estrogen contain plant-derived estrogens and chemically converted estrogens, but only a small percentage of the most active estrogen, which is estradiol. So in my experience, I stopped using Biest and Triest and went straight for estradiol. The estriol, yeah, we produced it when we were pregnant. Yeah, it had its role in our bodies, but it really wasn't a significant thing. The estrone is actually thought of as the cancer-causing estrogen. It's the pathway that is more responsible for the development of estrogen, breast cancers, and things like that. So that's why in menopause, women get so much more medical pathology because we're producing only estrone. So estradiol is typically the hormone that we primarily want to replace in a woman's body. So with all the compounding pharmacies out there and all the talk, Suzanne Summers' books and all the things that came out, and I read those because I wanted to see. And there's some very good information in those books. I was surprised. I really was. I went in it with a certain attitude, and I was very pleasantly surprised by a lot of the information that was in there. I really respect a lot of what she has said and done in those books. But, most of us, we live in the real world, and we have patients who want relief. They want cost-effective relief. They want to be able to go to a pharmacy anywhere that's around their house and get relief. And so we primarily still use, for the most part, pharmaceutical hormones, okay, meaning the ones that the drug companies produce. Now, when they went back to the drawing board, the pharmaceutical company hormones are FDA approved. There's numerous options like there is with compounding. Not as many numerous options, but there's a lot of different options available. They're carried in most pharmacies, Walmart, CVS, Target, what else? Rite Aid, Walgreens. Insurance generally covers them. There's a lot of research and data on these hormones to say, okay, this hormone at this dose absorbs this way through the skin, it gives them this level in their blood for this length of time, and it's excreted this way, and so we know kind of exactly what's happening. Compounding hormones are, since they're not regulated by the FDA, we don't know what the dose is. Doses can vary from batch to batch. We don't know exactly what the person is getting. Whatever the product is that the company sends the pharmacist that he or she mixes, we don't know exactly what that dose is. So we don't know exactly how your body's metabolizing it and the levels that your body has. There's a lot of prescriber comfort and experience with the traditional hormones, and most are bioidentical. Okay, so most of the hormones that we prescribe from a drug company are bioidentical hormones. Because what's bioidentical? It's the hormone that your body produces naturally. Okay, this is a very busy slide, but it shows the FDA-approved hormones for menopausal symptoms. And on the bioidentical column there, yes or no, you can see which ones are bioidentical and which ones aren't. The first one you see up there, Premarin, is not bioidentical. That's the one that we talked about already. I have not prescribed Premarin. I don't remember the last time I prescribed Premarin. The only time I ever do anymore is because some women have been on Premarin for so long in their life, they can't get off it. Their body goes through withdrawal and they just can't get off it. And so, you know, based on the situation, we keep them on the Premarin. Every woman is a participant in the decision on how we're going to manage you. If you want this, my first rule is do no harm. If it's not going to do you harm and it's going to help you, then certainly we need to consider what you want. So these women who are on Premarin and say, I know my risk, I know that it's not as good for me, I know that I might get breast cancer, I know that I might get, you know, more a risk for heart disease, I want my Premarin, I want my quality of life, more power to her. As long as she knows the risks, then I'm comfortable with that. The bioidentical hormones that we use, the best route of administration is through the skin. And most of the compounded hormones that are produced are not oral pills. When something is a pill, it has to go into your stomach, go through the liver, get metabolized, and it has other effects on other parts of the body and cholesterol and things of that nature. So the best way and the safest way to deliver estrogen is through the skin. So we use patches, we use creams, we use gels, we use sprays. There's many, many different routes of administration for a topical estrogen. And then we get into some of the others down here that are not bioidentical again. The estradiol, ethinyl estradiol, that is actually the estrogen that's in birth control pills. And so in lower doses, we use that for menopause, but it is not a bioidentical hormone. Progestins, the micronized progesterone, the Provera MPA, widely used. We still use Provera a lot, or I use it a lot for things like bleeding irregularities. We want to stop someone's bleeding. There's medical indications for Provera, but in hormone therapy, we want to use bioidentical hormones. So if you look at the category that says yes, it's bioidentical, you see micronized progesterone or prometrium. Prometrium is used in hormone therapy in a woman who still has her uterus, because remember, we need to protect the lining of the uterus. Now, progesterone does not come in a good bioidentical transdermal form. So it's a pill. We don't have a good, at least not in the pharmaceutical world, a good option for a patch or something with progesterone. There have been patches created with progesterone that are not really used. They're not bioidentical. So the micronized progesterone, or the Provera, is what we prescribe. And that usually, I tell my patients to take it at bedtime. It makes you a little drowsy. Most patients like that at bedtime. So they have their patch or their cream or their gel or whatever, or their pill. A lot of women are taking bioidentical estrogens by mouth. And they take their progesterone at night. The others down here, these progestins are man-made progesterones that are common in some of the hormone replacement therapy products, but also in birth control pills. They're just at a much lower dose. Then the combined hormones like this. The conjugated estrogen and progesterone is the Prem phase. So you can see that all of the combination hormones are not bioidentical, which is why we use one and the other for that. So what's the verdict in all of this? The verdict is all hormone preparations, whether produced from a drug company or produced from a compounding pharmacy are synthetic because they are produced in a lab and given to you in whatever form they're made to be in. The only natural hormone is actually pregnant mare's urine. It's a biological product. So go figure, the only natural or biologically produced substance is pregnant mare's urine. Now, by the time it gets into Premarin, it's not natural anymore, but if you think about what natural means, it's a biological product. Most FDA-approved hormones and compounded hormones are bioidentical, and most of us in women's health, that's all we use are bioidentical hormones. However, the disclaimer in all of this, hormone therapy in any form may be contraindicated for certain women. There are certain women that cannot take hormone therapy. Always discuss your risks versus benefits with your healthcare provider, which is why it's so important to come in, talk to somebody who's well-educated and works a lot with menopause, and discuss what your personal history is, how hormones may or may not benefit you, and the choices and the products that you would like to choose. Okay, so that's basically my little talk. Anybody have any questions about any of this? Speak up, please. Someone has to have a question. Yes. Okay, the question is, which pharmacy do the compounding prescriptions for me? There was a pharmacy in Santa Ana. There is a pharmacy in San Diego. I can't remember the names of them. It's been a while since I've used them. But the ones that are farther away, they mail the products to their patients, to our patients. So we can call the pharmacy, prescribe it over the internet, just fax them a prescription. So the one in Santa Ana, like I said, I can't remember what the name of it is, and then there's one in San Diego. Those are the two that I pretty much use. And it boiled down to Santa Ana was close because there's one in Santa Ana, one in Costa Mesa, one in San Diego. Santa Ana was the one I primarily used because it was local around this area, so women could go there and pick up their products. There's a lot of compounding pharmacies. There's compounding pharmacies all over, but we hesitate to just send you to any compounding pharmacy unless we really are comfortable with the products that they're producing.
Have you checked out the one in Anaheim? It's like something like the
and which pharmacy is that?
It's across street from CVS. It's up on the hill right there, and we just love it.
Yeah, and again, when a compounding pharmacy does this a lot, they get very, very good at what they do. And I actually trust the pharmacist to guide me on how to write my prescription. I feel like I become maybe the vehicle between the pharmacist and the patient for the patient to get what they want, legally through a prescription. But the pharmacist is the one that guides me, and that's why the ones that I got comfortable using, like I said, it's been a little while now, but I was very, very in close contact with them.
Question, so if you don't have a uterus, so is Premarin really, it still can cause breast cancer?
It's the women in the study that did not have a uterus. They did not see an increased risk for breast cancer in the Women's Health Initiative, that arm of the study. Now, I go to a breast specialist in Orange, and he's a very well-known breast doctor, and I asked him point blank, does estrogen use cause breast cancer, yes or no? And the answer was yes. You can't say it doesn't, because it does. How much does it cause? How much causes it? How long will it be before you get it? If you get it, nobody knows the answers to those. But you have to be aware of the risks of the hormones, and that's why talking to your provider is so important and understanding what your risk is. A 50-year-old woman who is just miserable and can't function in life, yes, she knows that maybe there's a risk down the road of breast cancer, but right now she wants a quality of life. I had a patient come in. She fought hormones for years, and personally, I've been on hormones since I was 44, and that's been well over 10 years now, okay? So I feel very comfortable using hormones personally. I relay a lot of my personal experience to my patients. But this woman in particular was miserable. I mean, she was just miserable. She was just scared. She was scared to death of hormones. So one day I get a phone call, patient so-and-so wants to see you right now today. I said, well, gosh, okay, bring her in. What's wrong? So she comes in and she says, okay, write me a prescription for hormones. I said, what happened? What made you change your mind? She says she was like a vice president of some company. She was up in front of a room full of men giving a presentation on something, and she started to sweat. And the sweat was dripping down her face. It was dripping off her nose. She could feel it going down between her breasts and down her back. Face was beet red, and all the men were like looking at each other. And she goes, I just lost all my credibility. Right then and there, I just lost it. She goes, I cannot function in my capacity and live like this anymore. And that's where I tell my patients, when you're ready to do something is when you know in your life, okay, I've had enough, let's do something about it. So I prescribed her the hormones that I was using and that I used primarily, and she was much happier when she came back to see me later. Yes. Yes. Yeah. Mm-hmm. Right. Yes. I think I know what you mean. You're wondering if a woman has a history or a family history or risk for breast cancer, would taking hormones worsen that risk or cause? Yes. Okay. Yeah, if a woman has a history of breast cancer, let's go back to breast cancer now. Let's talk about real numbers there. 1 in 8 women will get breast cancer in their lifetime. Okay, that's a lot. So if you look around the room, you know, there's more than 8 people in this room. And of those people who get breast cancer, 80% have no risk factors, no family history, nothing. So what that means is the general population, there's no risk factors, and they get breast cancer. The ones who have a family history, and especially genetic testing shows that they have that cancer gene, we probably will not use hormones on those women. A woman who has had breast cancer, of course, we won't use hormones on. But the dilemma comes when a woman has had breast cancer and she is treated, and she comes in because she's miserable with menopausal symptoms, but she can't take estrogen. So then we get into the whole discussion, which is kind of above the scope of this. What do we do for those women? We've used things like antidepressants, certain other type of preparations that we can use to try to help these women's symptoms, but they're a difficult population. The other area I want to bring up about bioidentical hormones, and there's a man in the room, but I'm going to talk about vaginal health anyway. One of the main, long-term effects of low estrogen, okay, is genitourinary atrophy, meaning everything shrivels up and gets dry down there. And women start losing urine. They can't have intercourse anymore. They get vaginal infections. They get urinary tract infections. So there are vaginal estrogen preparations, which were on that list that I didn't specifically point out, that can be used that are bioidentical to replenish the estrogen that's needed down here. They are not systemic estrogens. So women who are afraid of estrogen or cannot use estrogen for whatever reason often will talk about a vaginal estrogen for local treatment. And if a woman has had breast cancer and comes to me with vaginal complaints primarily, I will confer with her oncologist. We'll talk about what her risk is, and many times the oncologist will say she is safe to use a vaginal estrogen, which is better than nothing. So again, it's all very individualized. But a woman who has a strong family history of breast cancer, has the BRCA1 or BRCA2 gene mutation, which means she's likely to get breast cancer, using estrogen in her is probably not the best thing to do.
So is it Premarin and vaginal estrogen?
Premarin is in a form that is vaginal, Premarin cream. That is not bioidentical. We still use that occasionally, but primarily we use estrase or estradiol cream. That's where a compounding pharmacy can come in very useful as well, because they can compound vaginal products that we don't have available to us. There's a tablet that is also vaginal called Vagifen that we can use, But compounding pharmacies can formulate a little bit of testosterone in it. The absorption is much better down in that area in terms of the hormone getting into the system. So a lot of the compounded preparations actually are applied to the general area for systemic use, and they can be given in much lower doses. Testosterone is one of the things that we can sometimes add in that one as well. Yes?
So if you call vaginal hypertension, do you need to also use that for progesterone cream to balance it?
Right. The question is, if you use the vaginal estrogen, do you also need to use the progesterone cream to balance it? The answer is no, because the vaginal estrogen is considered low enough dose where you're not getting the uterine effect that you would with a systemic hormone.
You have to test it for that, and like when you test the blood test or
For
test, so that vaginal you to know how much you need to use
no.
the dosage.
If you came to see me, I would know what to prescribe for you based on your symptoms and what I see. But no, you don't need any kind of testing for that. It's a given that this is going to happen, unfortunately, as time goes by.
When I went through menopause, I went to my gynecologist, and of course he didn't know anything about natural hormones. And so I told him that I had read all of Dr. Johnny's books,
Mm-hmm.
and I told him I was know that, and I got on natural progesterone cream transdermally.
Mm-hmm.
And it really helped all of my menopausal symptoms and all that. And I was tested for my full life for a few years. And I just stopped doing that, and I just continued with the low dosage.
Mm-hmm.
Twice a day, every day, you know.
Right.
I did everything I was supposed to do. And I did it for like 10 years. Then I had an ovarian cyst burst. And this is in the hospital for a week and all that. And with all the reading and everything that I did, and all the people that I talked to, they said that when Dr. Lee wrote all these books about using the progesterone cream, he was right, but then he died, and he did not continue the research.
Mm-hmm.
So now new research shows that using it transdermally is not good because it's fat soluble and accumulates in your tissue, which throws off all the rest of your hormones, which can cause you to develop cysts.
And that's
why I have my cysts the size of 11.
wow.
Yeah,
That's rare in a
so anyway,
older woman.
I got off the natural progesterone cream. I thought I was doing everything right, and come to find out now they say that you have to be tested, and then you can only use a very low dosage, like 1/16 of whatever the dose is, and it's supposed to be used on your labia, down there, or on your rectum, and that's it. So now I'm not doing anything because I'm totally confused, and now I'm kind of afraid
Right.
because of all the hell I went through with the cysts.
Right. And that's the typical type of patient that comes to me and says, you know, what do I do? How can you help me? And as you pointed out, everything is a work in progress, and we're constantly getting new information, conflicting information. One day it's good, one day it's not good, now it's good again. So, you know, it's all a very complicated issue between you and your provider. Like I said, my patients also are the captain of their ship. You know, I will do what you want me to do if it is medically sound and not harmful. But that's, you know, a perfect example of somebody who had come to my office and pulled out a big Ziploc bag full of syringes, all different compounded hormones. Put it on the table and said, this is what I'm using, nothing is helping me. She spent thousands of dollars on these syringes. And I said to her, if you trust me enough, do something for 3 months. Let me prescribe for you a bioidentical estrogen patch and a bioidentical progesterone pill that you'll take at bedtime. And let's do that for 3 months. If you don't like it, we'll stop. No harm done. Give it a try. 6 years have gone by and she's still on it. So I know from me personally, I've tried all the compounded hormones. I use myself as a guinea pig. I've tried them all, and my favorite is the patch, and I don't have to take the pill because I don't have a uterus. I know you get more information on my health than you probably want, but again, I'm a human and a woman just like you guys, and so I want you to learn, you know, also from my experience. So, You know, these women come to me trying all sorts of things, and what it all boils down to is what is going to work for you. Numbers on a lab slip, I don't care what the number says, I care how you feel. How do you feel? You're sitting in my office, tell me what you're experiencing. I don't care if your number says that you shouldn't feel that way because your hormone levels are this. You feel that way, we're not going to look at that number. So, absolutely. Oh, yeah. I wouldn't give somebody hormone replacement therapy if their estrogen level is so high that we figure you're having symptoms, it's probably something else. And that happens a lot. A woman will come to my office and we'll think, okay, I'm in menopause or perimenopause, and I need estrogen. And we'll say, well, let's draw some labs and see. And their estrogen level's like 300. And I said, well, no, it could be your thyroid. It could be something else. We need to keep looking. So we do use labs very, very routinely. And one of the ways we use the labs the most for menopause is for a woman who's in her 40s, going through perimenopause, who's on a birth control pill because she could still get pregnant, wanting to go off the birth control pill at menopause and go on a lower dose, which would not protect her from pregnancy. So we will test to see what the blood level shows and confirm that the ovaries have stopped working before we lower the dose. And she winds up 50 years old and pregnant and mad at me. Yes?
Is it ever advisable for people that don't have a lot of symptoms to start taking them to ease the transition so that you don't have those symptoms?
That's a difficult question to answer. The obvious answer is no, it is not indicated to do that. Hormone therapy is indicated for the treatment of vasomotor symptoms for the lowest dose for the shortest amount of time possible. Now, going back to the Women's Health Initiative and these women who had problems from hormones, you have to also realize that, like I said, some of these women were 10, 15, 20 years after menopause before they used these hormones. And then they started putting these hormones in their body, which were not even bioidentical. They were, completely foreign to the human body, and they started to have problems. Women who are brand new in menopause, that are in their 50s, maybe mid-50s, late 40s, whatever, having symptoms are the ones who the benefit of hormone therapy outweigh the risks, okay? And we're looking also at bone protection. When your estrogen level goes down, your bones can start to thin and you can develop osteoporosis. And the most rapid decline happens within the first 5 or so years after menopause. So if a woman uses hormones at that point, not only is she getting a quality of life back, she's also helping to prevent osteoporosis. Now, don't use estrogen as a preventive medicine for osteoporosis. There are other things we can do. We use them for symptoms, and that's what we have to keep telling our patients. It's for vasomotor symptoms. There are other benefits as well. The women who are right at menopause and shortly thereafter are the perfect people to be using these hormones and getting more benefit than rest. Mm-hmm.
Wouldn't they sit down and explain all this to you before you started?
Not necessarily, because they have a patient every 10 minutes or every 15 minutes, and they walk in the room, and it's hard. With the medical climate the way it is today, patients are scheduled every 10, 15 minutes. In some practices, they don't have time to sit down and talk about this. And many of them, but they know that they have, if they spend a half an hour in this room, then they're going to be backed up, and by the end of the day, they're going to be 2 hours behind, and their patients are all going to be mad at them. It's a difficult thing to do between what's financially sound for the practice and what is best for the patient. We generally can cover it through insurance because you come to me with menopausal symptoms, irregular periods. We find things that we can bill that are billable expenses that we can use while we have this conversation. Yeah. So if we bill it as a menopause consultation, typically no, but we have become pretty educated in how to creatively, and I won't even say creatively bill because it's honest billing. We're not being fraudulent by any means, but by documenting the things that you will get reimbursed for.
Maybe I understood wrong, but I just issued what you said here. And there's the thing that she was talking about, synthetic versus bioidentical hormones, was the synthetic was more of a band-aid, take care of the symptoms, but in terms of our bone loss number, I thought maybe I understood it wrong, but she made it sound like And the doctors that she was interviewing, their conversation was the bioidentical ones actually replace help with our bone loss, where the synthetic ones don't do anything for our bone loss. Of course, we take calcium and that, you talked about that, and vitamin D, you know, all those good things. But what is your take on that?
Okay, remember what we're talking about with synthetic. What does synthetic mean?
Right.
Okay, synthetic means you went to a company, they produced a product and gave it to you that's bioidentical.
Right.
So compounding hormones are all synthetic.
But what she's saying, is there any truth to that, you know, the bioidentical, the one, or is what we're getting, I think, like Dr. Cameron, you know, and after I think workshop and people every couple months. Is that you know, possible? Because they say don't know if you have, you know, unless you do those tests, and even then.
You talking about your bones still? Any estrogen theoretically will help with bone protection because there's estrogen receptors in the bones, and that's what protects our bones before we go through menopause. Now, the way a woman's body metabolizes whatever the product is and how it eventually gets to the bone and preserves the integrity, it's hard to say. There's really no answer to those questions. And again, it's, you know, our life is a series of choices. You know, if I chose to drive here and risk a car accident, you know, we have to choose our risks versus our benefits. But I can tell you that women who break a bone later on in life, that's probably one of the #1 ways they die. They break a bone, they end up in a nursing home, they get pneumonia, and they die. A lot of times within 1 year. So bone issues, bone health is a huge part of menopause treatment. We know estrogen can help with that, but more importantly, it's not only the young girl that was sitting there, but it's the girls that age that we need to talk about calcium and vitamin D, because your bones reach maximum strength at about age 30. Then they slowly decline after that. So it's the younger girls that we need to really talk about, and those are the girls, and I know I was the same way, I don't worry about that when I'm old. I'll worry about that later. But I do know that estrogen will help protect your bones, especially in the first 5 to 7 years after menopause. At that point, when the menopausal symptoms are gone and hormones are no longer indicated, there are other treatment options for osteoporosis. Yes. You know, I haven't had a whole lot of experience with the pellet. I know that there are usually numerous pellets they put in, not just one, and I don't know sometimes. I mean, I know I worked with a girl who had like 6 or 7 pellets under her skin. That worries me a little because when they're in there, they're in there, and if you have a problem or you don't really know what's going in your system, personally, I have a problem with things that I don't know how the body's going to react to it. If it's a cream, I can tell you stop using the cream. If it's, you know, a spray, and say don't spray it on anymore. If it's a pellet, the pellet stays under the skin and the medicine absorbs from the pellet. Yeah. No. Well, that being said, there may be, and there probably are pellets that are absorbable, because I can't imagine a lady having a bazillion pellets all in her body and they never go away. Well, that's what the understanding that I have. That's the pellets that my friend was using. They had to go in and remove the pellets after X amount of time. So, yeah. Yeah, it stands to reason they should absorb, because why would you want all these things in there that aren't going to go away? But I'm not sure exactly. I don't have a lot of experience with the pellets, I'll just be honest with that. Yes? Approximately. Well, it depends on the person. It depends on your bones, what your DEXA scans are showing, how much bone health you have. No. The only indicator for hormone replacement is vasomotor symptoms. Bone health is a good side effect, if you want to call it that, or a extra added benefit. But we can't use estrogen as a treatment option for osteoporosis in and of itself.